Thank you for that kind introduction, and I never knew that my anesthesia colleagues even noticed when I was in the room, but thanks anyway. What we're talking about today is something which, of course, is one of the most common and problematic complications of childbirth, which is postpartum hemorrhage. So we're going to have the three perspectives: obstetrics, blood banking, and anesthesia perspective. And Alex Butwick has been promoted to director of the blood bank at Stanford, although our director of the blood bank doesn't know that yet. So in California, we have an organization called CMQCC, which is the California Maternal Quality Care Collaborative. It's a big mouthful, but what it is, it's every obstetric hospital that does deliveries reports data into this big central data bank that is managed on behalf of the state at Stanford. And by using these large databases, we've embarked on certain programs to improve maternal health. One of the first ones was the obstetrical hemorrhage, and there was a task force put together to come up with recommendations on how to approach postpartum hemorrhage, and we're just finishing another one on preeclampsia task force, which I've just co-chaired, and we'll be coming out with a similar toolkit to hemorrhage within the next month or so. And so we continue to work very closely with the state to try and improve healthcare. One of the things that is very clear about postpartum hemorrhage is this review from a doctor's company looking at closed claim review of maternal deaths from postpartum hemorrhage. And one of the big issues, of course, is all the Ds, denial. It's always interesting that often the obstetrical team are always in denial about the level of blood loss. And we all know that these young patients can tolerate blood loss with very little change in their vital signs or subtle changes until suddenly the bottom falls out and we have a major problem. The other Ds are delay in delivery of products, delay of giving the products, mobilization of treatment, the delays of waiting for cross-matched blood, that frustrating, you all hear this, it's another 15 minutes, or we start with, it'll be 15 minutes, and then 15 minutes later, it's another 15 minutes, and another, and another. So waiting for cross-matched blood is an exercise in futility in many cases. And we need to utilize our massive transfusion guidelines with O-negative blood. And then underutilization, not giving enough. And the CMQCC and the Hemorrhage Task Force wanted to stamp out at the bottom of the screen denial and delay and improve management of obstetrical hemorrhage by reducing the risks, making sure you perform some type of admission risk assessment, reduce the Ds, quantify your blood loss in a much more systematic way, follow a step-by-step plan, do not repeat the same failing step again and again. I think Einstein once said, repeating failure is stupidity or something, but if you keep using the same technique over and over again, which is not working, you need to move on. And improve treatment with blood products, give it enough and give it fast enough, and always enhance teamwork and communication. And the four major recommendations finally from the task force was we need to implement standard protocols, improve recognition, improve the response, and improve the reporting. And there's a big initiative going on which is called the Collaborative, where hospitals are reporting their results, and the data to date, at least the preliminary data, shows a vast improvement in outcomes by implementing some type of program such as this. We all know what postpartum hemorrhage is. These are the definitions, but we also know that a cesarean section, you lose 1,000 cc's of blood, uncomplicated vaginal delivery 500, and there's some definitions of postpartum hemorrhage. These are old definitions, not sure whether they still hold up, but our estimated blood losses are always inaccurate, as you know. We have started a quantified blood loss program at Stanford as part of the hemorrhage recommendations from the Hemorrhage Task Force, with under buttock drapes with graded with measurement and actual measurement of blood loss, including all of the towels and the laps and all of that for vaginal deliveries and C-section. And it is interesting that if you'd really quantify blood loss carefully, you may find a different picture to the estimated blood loss, where you just say to we say to the anesthesiologist, what's the blood loss? And they say, what do you think? And we say, 650. They say, okay, sounds good. That's kind of where we're always at, and it's probably okay for most of the cases, but it doesn't help us in terms of quantity. So ACOG in 2006 became very alarmed with the fact that severe bleeding is still such a major cause of maternal death worldwide, and most of it occurs in the first 24 hours post-delivery. These numbers are staggering, concerning, and of course, much more common in the developing world. But sometimes in this country of ours, you wonder if we have the same statistics as the developing world in certain pockets, given the morbidity and mortality that we see. And the sequelae, short of death, are also not something that we really want to, it is something that we want to prevent. So this is the whole thing. We're in Northern California right now. There's a big home delivery movement. As I always say, quoting a famous neonatologist, home deliveries are for pizzas, not for babies. And one of the reasons is that although we have been able to identify risk factors, we all know it suddenly can occur without warning. And we must all be ready to take care of this. And if you're in a remote mountain cabin in the hills above Santa Cruz, I don't think that's the ideal place to take care of a postpartum hemorrhage. Clinical drills to enhance the management of hemorrhage have been recommended by JACO, and we should take those lessons, and we should work on teamwork and how to manage postpartum hemorrhage. The major causes of postpartum hemorrhage are very well known to you all. It's urinary. Urinary is probably the biggest number of patients, and that's something that we really need to be able to implement management in our sleep. Genital tract laceration, including uterine rupture, of course, is another cause, but those are usually, we kind of know about those because, for example, somebody's had a previous cesarean section, and I know Dr. Mason's going to talk about TOLAC, VBAC, which is another issue that we have to face every day. But uterine atony still stays number one. Retained products of conception is another cause of postpartum hemorrhage, much less common. And of course, with a rising cesarean section rate, the absolutely staggering incidence of placental implantation abnormalities like placenta accreta, placenta previa and accreta. And all of you who work in any major hospital have seen this increasing incidence. We at Stanford now, as a referral center for these patients, we actually have our own placental disorders hotline where you can just pick up the phone and call one number and refer your patient in. And as Alex Butwick will tell you, we're probably doing 2 a month and sometimes more of these massive placenta accretas with incredible complexity. Coagulopathies are a very uncommon cause of urinary. What causes atony? Well, atony comes from labor. Prolonged labor, augmented labor. Do I have a pointer? Whoops. I guess, am I supposed to have a pointer somewhere? Oh, here we go, sorry. Uterine atony from prolonged labor, augmented labor, rapid labor, it all comes down to labor, which leads to atony. And the other one is overdistension. And overdistension, of course, occurs with twins, triplets, polyhydramnios, and then other things like operative delivery, chorioamnionitis. Those all contribute to atony. And you can see that many patients, when you walk in tomorrow into your labor floor, are going to have multiples of these risk factors for uterine atony, and that's why it's the major cause of problems. Well, an obstetrical approach to postpartum hemorrhage, number one, good visualization. How many times have you walked into the labor room, LDR, LDRP, the music's playing, the lights are low, the dog's in the room, including the rest of the family, everybody's in the room, nobody can see anything, the patient's, you can hear a little drip, 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 and it's the patient bleeding out in front of you. So the first thing you should do, turn on the lights. That's my first, it's not on here, but I'm telling you, number one, when you called, turn on the damn lights so you can see what's going on. Because oftentimes I see people groping around with inadequate lighting to try and figure out what's going on. First thing we do is palpation. And with palpation, you can do bimanual compression. And with atony, that may be all you need to do. Is you just examine the patient, you figure out that they've got atony, you start massaging the uterus, and they stop bleeding. And that's often all you need to do. You can also, if there's adherent placenta, you can try and remove the placenta, and then you may have to move on to instrumental intervention. The lights need to be on so you can inspect them for lacerations, because you can bleed a lot from a laceration. The vagina has got an incredible amount of blood supply, and the vulva. And then obviously send off your labs. But this is a rare cause, so don't spend all the time drawing labs. You know, just get in, do your bimanual, see if you can get the placenta out. Obviously draw the labs, but that's not something that you should spend a lot of time on. And then obviously you need to inspect them for lacerations. Laparotomy needs to be thought about, so get ready to mobilize in case all these other interventions fail. And then do what I call the M&Ms, massive transfusion guidelines, implement your massive transfusion protocol, and then mobilize people and get moving. And if you have a mask suit, which are the military anti-shock trousers, that sometimes works very well for resuscitation in these patients. This is the mask suit where you just put the patient in here, and this is all Velcro, but what this does is it basically takes blood from the lower body, pushes it up into the central system, and allows you to resuscitate the patient much quicker and easier. We used this a lot more in the past than we do now, but it's something that should be thought about and can be used and has been used in the military and by ambulance crews on the road. The most frequent cause of uterine atony, the most frequent cause of postpartum hemorrhage, of course, is uterine atony, and we've spoken about the risk factors, but all of these risk factors are often present in one patient. So, as I mentioned before, the first thing you do is bimanual compression, and while you're doing that, you are giving the patient uterotonics, oxytocin, methogen, 15-methyl. You can use PGE suppositories, and a lot of people now are using misoprostol rectally, and these all seem to work very, very well. The bimanual compression is very simple, and as I said, this may be life-saving, but it's so interesting to see how people do not implement this. Clearly, by doing this, putting a hand in the vagina, getting under the cervix, and compressing with an abdominal hand the uterus, it would be very nice if we had a nice epidural block, because it is a painful procedure. But even if the patient has no anesthesia while we're waiting for you to help us out, this needs to happen because it can be a life-saving maneuver. With bimanual compression, you can stop the bleeding almost immediately. Uterotonic agents we've already spoken about, and everybody knows what the doses are and what the contraindications are. Once you've finished with the with your initial simple maneuvers, one of the things you can think about doing next is a tamponade or packing. The tamponade is using either just packing, if you don't have a fancy battery balloon, or there's these double lumen balloons now, double balloons, all kinds of fancy things that I don't know how much they cost, but you can simply take a, $5 Curlex, put it in some betadine, and then pack the uterus with that if you're in extremis. You can also just use a simple Foley catheter, 30 cc catheter, put it up into the uterus and inflate it. Because what you want to do is create a space-occupying lesion, so to speak, so that the wall of the uterus then contracts down on itself. You can use the old Stocken-Blakemore tube, but right now most people will use some version of this balloon, the tamponade balloon. The trade name is Bakri. I have no stock, but Dr. Bakri from Saudi Arabia is the one who started using it. And we have a whole system of using the Bakri balloon. So uterine tamponade is something that should be used after you've tried your bimanual, so that you can allow the uterus to contract down, and sometimes that will work too. If you're going to use packing like Curlex, you need to pack it all the way up to the fundus. Again, we need good relaxation, good pain control with all of your help to be able to do this effectively. And the packing has been shown in a number of small studies, and they've used Curlex, again, some with balloons, but Curlex has been shown to be quite successful. And uterine packing may be a reasonable alternative to further surgical intervention in patients with intractable obstetrical hemorrhage. In fact, some of the early data, they used this for placenta previa bleeding from lower uterine segment or from a focal accreta. Packing was used very successfully for very focal accretas where you could just pack the uterus contracts down, that bleeding site will then be controlled. The balloon, again, Dr. Bakri designed this, and this is basically the essential elements of the balloon. It's just a space-occupying lesion. And he used it in his initial study in 5 patients, and this one was where he used it in patients with placental implantation abnormalities and found it to be quite successful. And there was one woman actually with a cervical pregnancy. So again, space-occupying lesion, you can use a Foley catheter, you can use Curlex, and you can use a fancy Bakri, and there's some other new balloons. What you do have to do, remember, is the vagina also has to be packed, otherwise the balloon will just start coming out. So it has to be sort of pressure from below and pressure in the uterus, and that's why this double balloon thing has been developed, but I think they cost a lot more than the simple single balloon. And again, Foley catheter works just as well. So once you've done your bimanual compression, now you've done your tamponade and you're still having a problem, you may need to then be sure that you've got no retained products of conception. Go back to the OR. Do not hesitate. Go back, put her to sleep, or if she's got a good block, use the block. Whatever you, I always leave that up to my anesthesiology colleagues to decide which way to go, but we need good operative analgesia, anesthesia to do a curettage. And then if that doesn't work, then you may need to do a laparotomy. But you need to go stepwise towards that, and do not hesitate. If the patient's continuing to hemorrhage, you must get control of the primary source of the hemorrhage. People are often reluctant to intervene, to do the laparotomy, but once you've exhausted your more conservative measures, you do need to move. And once you do a laparotomy, you can start with the uterine artery ligation. Then you can go to what's called the brace sutures, or the B-Lynch sutures. Repair rupture if there's a rupture. Do not do a hypogastric artery ligation is what I tell my colleagues, because unless you're doing it all the time, it's in every textbook and in every exam they have hypogastric artery ligation. Where you do the hypogastric artery ligation is a very dangerous place, because you've got the hypogastric vein. It's very, very vascular there, and if you damage the hypogastric vein, that patient will die of venous hemorrhage, because that will dissect back into the lumbosacral plexus, and you'll never be able to get control of that. So I tell general obstetricians, do not do this. If you don't know how to do it, move to hysterectomy. You all know how to do hysterectomy. Very few people know how to do a hypogastric artery ligation unless you have an oncologist who does this all the time. This should be not used. It can do more harm than good. You can see here, this is just the uterine artery ligation. This is where you just tie the uterine artery as it comes off down low at the level of the cesarean section. You can also do a high ligature. Certain techniques you have to use. Obviously, you do not want to get the ureter, which is right in this area. That's not a good idea. But a uterine ligation with a low ligature or a high ligature or both will often be successful, always being in mind that the ureter comes down here. Now, if you look at this and you see the internal iliac artery right here, you've got the external iliac artery over here, and you've got the vein over here. Now, remember, if you tie off the wrong, if you can't figure out which is the internal or external iliac, and believe me, it's not all that easy in a pregnant woman with these large vessels. If you happen to tie off the external iliac artery, that's not a good idea. That patient's going to have some problems with her leg, which may actually fall off. That's not a good idea. So this is really a dangerous operation unless you are actually very familiar with this area, because there's too many vital organs within a few centimeters of each other. So what about the B. Lynch or brace sutures? And B. Lynch is actually the name of this gentleman, Dr. B. Lynch. And he started with a small series, and there's been a number of larger series using these types of sutures. And this is the one where, you know, the joke, where you open the textbook so that surgeon, while they're doing the surgery, can figure out what to do. This is one of those where you actually sometimes have to open the textbook because it's hard to remember. But essentially, you just go in right where the cesarean section incision is. This is number one. Number two, you bring it over like suspenders, and you go behind, you go back behind, and you come back over again. Again, as I'm talking to you, you're all confused, but a picture's worth 1,000 words. And that's what you do, and ultimately, this is the way it looks from the back. You come over the top, you go back through between the uterosacrals, go back over again, and then you just tie it up front, and that's what it's supposed to look like. And basically what you're doing is you're compressing the uterus upon itself, and it's shown to be remarkably effective. We've seen that work on a number of occasions, and that's very simple to do and something that you can do before you move to hysterectomy. There's another one that's called the hemostatic multiple square suture method, where you actually take portions of the uterus. I know it looks like a funny face with two hands going down, and these are the eyes, but you basically just, you go straight through and through the front and back wall of the uterus, come back out again, and you tie off these squares, and you can do them in the lower segment as well for bleeding previa accreta if you've got focal bleeding accreta, not for big ones. And basically you're doing the same thing, but you're doing more local compression as opposed to the B. Lynch suture. The B. Lynch is actually more easy to perform, in my opinion, than the other one, and it seems to work very well. You do it with a suture which is absorbable. You don't have to worry about the uterus sloughing off or something like that. The blood supply is just tremendous, and you don't have to worry about that. We already mentioned hypogastric artery ligation, and I've already said that I don't think it should be used because there's just too much going on in that hypogastric region. And then ultimately, if everything else fails, you've done your conservative measures, you've done your uterine artery ligation, you've done your brace sutures, your B. Lynch or your hemostatic square method, all else fails, hysterectomy is probably your next step. And people are reluctant to do that, obviously, because you're going to be eliminating childbearing. But in many cases, patients have already signed for tubal ligation and so on. So each case needs to be looked at very carefully. And if somebody's signed for tubal ligation and is hemorrhaging, you may want to move your hysterectomy up in the armamentarium as opposed to continue to use the less invasive stuff, because that patient's already said that she doesn't desire childbearing. I'm not saying that you must do hysterectomies willy-nilly, and I think you can just go through that process of more and more invasive procedures until you get the hysterectomy, but hysterectomy is the kind of last resort. And again, not all that easy to do, massive blood supply, but hysterectomy should be considered. And in terms of uterine atony, hysterectomy can be done as a supracervical hysterectomy. Remember, going after the cervix is another 25 minutes and, 1,000 cc's of blood loss sometimes, with the ureter at risk. So sometimes if it's just ureterectomy, which you can't get under control with all your other techniques, just do a supracervical hysterectomy, which really cuts down on your operative time and your blood loss. Pelvic artery embolization, one of the other speakers will talk about it more. We have used it sporadically at Stanford. We were very keen about it in the beginning. This is back in '99, and we had good results, and we had some problems. Uterine artery embolization remains a controversial procedure in obstetrical hemorrhage. ACOG in 2006 said the patient who has got stable vital signs may be a candidate for arterial embolization. So if it continues after you've done all your other procedures, including hysterectomy, and the patient is stable, that sometimes may help. However, we found that in one of our series, we had 2 patients who developed complications, which meant they developed thrombi in their femoral vessels from this procedure. So it still remains a little bit controversial. Finally, we just talk a little bit about abnormal placentation, and placenta accreta is the second most common indication for hysterectomy for obstetrical hemorrhage, and it's directly related to the increase in cesarean section rate. And if you have a placenta previa, you're more likely to have a placenta accreta. The most accurate diagnosis is by sonography and MRI. There are various degrees of placenta accreta. Increta means it's growing into the wall of the uterus. Percreta means it's growing through the wall of the uterus and may involve the bladder. This is one where the diagnosis is made intraoperatively, and you can see that over here we've delivered the baby, and here you can see placenta growing out through the wall of the uterus, this bluish thing, and we went ahead and did a hysterectomy. Hysterectomy is the treatment of choice for placenta accreta. No question about that, and one should be very cautious about trying to preserve the uterus in a patient who has got a placenta previa accreta, and should only happen if they're hemodynamically stable. Future childbearing is a huge need, and if it's focal. And we looked at our data on placenta accreta, on placenta previa and accreta. We had 113 patients, and we looked at maternal morbidity as defined as follows. And we found that a lot of our patients had maternal morbidity, but it was much more common statistically with invasive placentation, which means all forms of accreta. There's a lot of data about this, but bleeding episodes basically did not predict a morbidity. But being delivered on a scheduled basis for the whole cohort of placenta previa and accreta did not decrease morbidity, but if you had an invasive placentation, your morbidity was significantly decreased if you planned the delivery as opposed to doing it in the middle of the night or on a weekend. So with patients with invasive placentation, delivery at a scheduled time may reduce maternal morbidity. Neonatal morbidity was directly related to the degree of prematurity. So in a short period of time, and I think I'm not too far over, hopefully I've given you a sense of the obstetrician's approach to postpartum hemorrhage, particularly that with ureterectomy and the abnormal placentation, and I thank you for your attention.